Hello, guys, and welcome back. We are here to introduce an old episode of ours from our first season, I believe, right? You're not in an Edgar Allan Poe poem.
It's just me love dubbing because this is the Heart of Psychiatry episode.
This is the overlay with my former program director, and she specializes in cardiology and psychiatry and all the meanings of that. I think it's a super helpful episode. Super helpful clinically. We get into calculating QTC, and it can actually be much, much more helpful than you think. I once had someone say, why would a psychiatrist care about reading an EKG? And suddenly my program director's voice was like,
I link it
didn't
to
exist.
the Epic
Now
chat.
it exists.
Yeah, this
You're
is
welcome,
why psychiatrist cares about QTC. Yeah, even like the Frederica in Framingham, like calculations, I will still like go back and forth between those in the hospital. Like it's one of the pods that I think I use the information from it to the T just about at least once a shift when I'm on call, because it's hard to be on a 12-hour shift and not have some concern somewhere about QTC prolongation.
Totally agree. Yeah. I feel like I'm on consults lately for pediatrics, and so I'm in a different hospital now than I was. And I was like calculating the QTC, and my CL attending came in and goes, "She's calculating the QTC. Look at this one." And I was like, "Thank you, Dr. Funk."
Calculating. How many more seconds until the episode starts? 3, 2, 1.
How to be patient.
Margaret, take
Welcome
it
back
away.
to Call Her Doctor. Just a Call Her Daddy swoop. Hi, guys. Welcome back to the podcast. Season 2. Preston, how are you doing? Are you feeling wiser?
I don't know. Like, what's my character arc here? I think I'm calming down.
Villain?
That's it.
This episode should be coming out around the time when we're switching academic years.
Yeah.
Right?
So I'm going from like annoying little brother to like annoying cousin, I think. Through the lens of
why
like,
is cut? You just left the family tree.
it's because I'm branching out on my own, you know, like I'm gonna sprout my wings and fly soon, but not until I finish my 3rd year.
You're independent. Well, someone in my kind of training life is here with us today. This is one of my training mentors, Dr. Margot Funk, who is a psychiatrist, has been a really great mentor to me, and is going to help us today with her area of specialty in psychiatry around cardiology and psychiatry. Dr. Funk, thanks for coming and being on today.
Thank you so much for having me. This is, I'm really looking forward to it.
Well, we'll see what you say at the end of that.
Okay.
The experience is variable.
Yeah, people don't leave reviews on Yelp. So we always start with an icebreaker most of the times with our guests, just so we can kind of start with the human part of medicine first. And my question for you, as we ourselves and our listeners kind of go into the next academic year, is when you started residency intern year, and Preston, this is for us too, what was the topic you were most afraid of running into on like overnight call when you were by yourself, or that you would be like, I don't know what to do in that situation? Because one of mine was QTC.
Yeah, I didn't even know about the QTC then. So that certainly wasn't mine. Boy, that is a good question. I remember we took our first overnight call first year at the VA, and I think I was most concerned about the phone calls that we might get and having potentially suicidal patients on the other end, and not really knowing what to do if they were threatening to hurt themselves over the phone, where there's not a lot of control.
Yeah. And it's like, what are you gonna do as are you gonna call the police and like get a wellness check? Part of me is glad I didn't have intern psychiatry call for that reason. I feel like mine were QTC, and then on medicine, it was insulin. Like, actually, it wasn't on medicine. I did the first half of the year in psychiatry and hadn't done medicine yet. And it was during COVID. And so med school at the end got kind of like, there were no sub-Is. And I was afraid of like, I'm going to be on call over like by myself in the psychiatry unit. And someone with like uncontrolled type 1 diabetes is going to be like blood sugar 400. And there's like, what do I do? But it's like not technically a medicine consult. Well, that one would be. But, and then that happened like 3 times in the first month I was in psychiatry. And I was like, okay, I feel less scared. Preston, what were you scared of last year?
Ooh. So both of you mentioned, I guess, Dr. Funky mentioned like suicidal patients, which I resonate a lot with. I had like a couple scary moments like that my intern year, where I was like basically on a 3-way call with like the patient, my attending, and I was like, what do I do? Like, what else do I say? And like, those are all like kind of scary. I think what I'm always like most afraid of is really like violent codes. So we call them code greens, like behavioral codes. I think it's like really tough to confront patients in those scenarios, and like it's important for me to like want to be the doctor that like shows up to the code and doesn't just like put the orders in, but also like it is really like intense being in those moments. So I remember just being like when seeing that patient was like kind of agitated or anxious early in the evening, being like, okay, Preston, like this is what you're going to say. Like you're going to be firm, but you're also going to be fair. Like here's how you like approach this high intensity situation. I didn't really think a lot about medical stuff, which I should have, because we actually had a patient in euglycemic DKA get admitted to our unit, and that was like a straight nightmare. um, so blood sugar was not 400, but their like pH was like 7.2, and they were vomiting like coffee ground emesis and all this stuff. So we still had to call medicine. So I probably should have been worried about that, but I was just trying to pipe myself up to be confrontational, really.
I feel like I feel like all of these things, and it's like not knowing like situations where you're gonna have to like pull in an attending or pull in your senior, but especially the ones where it's not clear cut what you do next, and if it's gonna be annoying if you like call them. Like it's like if the blood sugar for me was like it's 290, then it's like, do I manage this by myself? And like,
Yeah. I had a situation when I was an intern overnight, and there was a patient that was hypoglycemic, like blood sugar 40. And, I get called by the nurses and they say, well, we have Kool-Aid. So we'll start with some Kool-Aid and we'll give him that. And, they called back, maybe 15 minutes later, like nothing. It's not helping. Like he's almost had like a gallon of Kool-Aid.
oh
And and so we try it again, and then it turns out it was diet Kool-Aid.
oh,
I was like, oh man, okay. So
at
what
the VA.
I learned, like, go immediately to the floor. Like, yeah, yeah.
Yeah. Well, I mean, this will come out in mid to late. It's probably June or July when listeners are listening to this, and we're starting our second season of this podcast. But I also think this time of year is always anxiety ridden, even when you're like Preston going into becoming like a 3 and kind of our junior or senior and know a little bit the lay of the land. I wonder for you in your roles in academics, like, do you feel like with the year turnover, do you stop getting nervous at some point? Is there hope for us?
You do.
Okay,
You do
good.
start getting nervous. It's funny though to talk about this, because I think looking back, there was so much that I should have been afraid of that I wasn't, which is probably a good thing. But there's just a lot that you don't know that you don't know. I think when ultimately you're on call and
I didn't even know there was
you.
diet Kool-Aid. I thought there was diet Capri Sun, and
Me too. Yeah, right.
so I'm an orange juice man from here on out.
We are not comforting the interns right now. It's like, don't worry, guys, it gets worse.
But you always call for backup, right?
Yeah,
Like,
ignorance is bliss, and don't be afraid of. Well, maybe not in medicine, but I don't know. I've never really been that afraid of annoying people. Maybe it's like a part of my personality.
true.
Margaret can attest to that, honestly. So when I call an attending at 2 a.m, I'm like, "Hey, I'm unsure." They're like, and then I'm like, "All right, well, look at us. We're here now. So let's figure it out."
You're awake now. You're like a puppy. That's
you
like,
and me.
Well, I mean, we should go on a walk now that we're here. So I think let's get into this subject, because this is a complex subject. I am in charge of this episode's outline and the name, and it is the heart of psychiatry, because I like to be pithy like that. But before we talk about any of the like concrete content, you mentioned you're like, I didn't even know QTC when I was an intern. So I wonder if you could tell us in your own words a little bit about the kind of work you do now,
Okay.
and what cardio psychiatry really is.
Yeah. Yeah. Uh, so right now, I have the really it's a privilege to see patients who suffer with some sort of cardiac illness, and that's the only patient population I see right now. And typically, I will see either folks who have suffered a cardiac arrest and survived. Many of them will have an ICD in place and may have then suffered more from ICD storms where they get repeatedly shocked. And then I see a cohort of transplant patients who have these just I mean, usually terrible stories of lifelong medical illness, and oftentimes their their heart suffers because of, let's say, a childhood cancer,
Mm.
and they had chemotherapy, and then that's affected the heart. Uh, so it's the people that I see have been through a ton of trauma with their medical illness, and so it's really for me like a joy and a very centering thing to get to work with them.
Mhm.
So when I see folks, in my clinic, we do a mix of both medication management and therapy. Uh, I love both pieces. I really like trauma focused therapy, and so that like fits in really nicely with this population. And then the medication management can be very complex, and really like getting into the QTC for real,
Mhm.
and doing risk assessment in people that are very, very high risk. And so that's fun too. Uh,
How did you, like, learn about obviously, there were times probably in residency where you learned about QTC calculations and then also working with medically complex folks, but how did you end up kind of being in this really sort of specific, consult liaison psychiatry role? Like, did you aim at it, or was it, like, kind of like, "Oh, I'm gonna do CL, and, oh, I really like this population." How did you end up working so specifically with these folks?
it completely by happenstance and different opportunities that arose.
She followed her
So
heart.
I
All right,
good.
guys, that's it. That's the episode.
So let's see. So I went into medical school thinking I would be an OBGYN, and really liked women's health. And then I ended up doing a master's in gyn onc, and did a lot of lab work and really liked the pathology part. So then I thought, oh, be a pathologist. I really liked all that precision work. And then psychiatry was my last rotation of medical school. And of course, as we like, it was awesome, right? You see people get better. It's so meaningful. So I decided to go that route. I had not many inklings about a desire to go into CL until probably my third year, where we had a lot of CL time, and my favorite attendings were CL attendings. They were just so smart. We we really learned like never miss catatonia, never miss narcolepsy, all sorts of things, right? And and so then I had a chance to be the CL chief resident, and that's where I think I really started to love the field. I did not do a CL fellowship. Uh, my life
Can you
situation
say
at the
that in Boston? Is that
I
allowed?
know. I know. Well, yeah, it's. I mean, it's been like clawing my way to get to this point. Um, yeah, my life circumstance at the time was that my husband he was starting fellowship in cardiology, which is another piece of this whole story. And so we moved to his fellowship location, which was at
Mhm.
Cleveland Clinic. And so I started as a CL attending there, and that's probably where I learned the most CL in that first year of being an attending. Um, yeah, and and because Cleveland Clinic was so heart specialized, just seeing a lot of complex patients there,
Getting
And
reps in with those common
absolutely.
consults.
Yeah.
Our listener base is like half people ensconced in healthcare and half people thinking about it or thinking about mental health. So just to say, CL is consult liaison psychiatry, which is like when someone's in the hospital and a psychiatrist comes and sees them, or in the emergency department, and can also be outpatient with specialized clinics like Dr. Funk does both of those. Um, and then would you define ICD just for folks who may be therapists or less familiar with it?
Yes, it stands for an implantable cardioverter defibrillator. It's basically an implanted device in the chest connected to the heart that will shock the heart out of a potentially fatal rhythm.
I remember the first time, I guess, like I encountered your expertise in this was when you lectured us on it. And I think it was on QTC, which we are lucky to have you at our program. I did send Preston like earlier today. I was like, this is the resource document that is on, I think, the APA website that you helped co-create in 2018. So we're going to take a quick break. And when we get back, we will get into the QTC of it all, as well as then kind of later in the episode talk about treating patients who have this kind of medical trauma, who are struggling who you want to help live a meaningful life with limitations from cardiac conditions, and also processing what's happened leading to them getting to your clinic.
And
So
we have
we will
some practice vignettes too.
and we do. Sorry, I forgot
Ooh.
that. They're going to edit, splice that together. Can we like get like a DJ remix and just
Okay. Yeah, play the red tail hawk scream. Let's go to the break.
Break.
Margaret and I are very excited to tell you about a healthcare news podcast that just came out called Medlines.
It's a quick weekly wrap up of everything in our field, from breakthrough discoveries and research to politics and, of course, medical pop culture.
I think the best way to conceptualize this podcast is it's like NPR's Up First, but for medicine. So they're short, to the point, with episodes no longer than 15 minutes.
And it's written and created by an amazing team, some of whom you might recognize, Dr. Glaucomflecken and Lady Glaucomflecken, as well as many people here at the Human Content Podcast Network.
With thanks for their inaugural sponsor, the New England Journal of Medicine. New episodes of Medlines are out wherever you get your podcasts, with new episodes out every Friday.
So, Dr. Funk, as someone who is not a cardiologist or married to a cardiologist, can you explain to me what the QTC is? Because I feel like I've memorized how it is on an ECG, but I don't really know what it is really.
Yeah. Okay. So we'll start at broadly and work our way in. So on the EKG, the QT interval is quite literally the interval between the beginning of your QRS complex and the end of your T wave. That interval actually represents both depolarization and repolarization of your ventricles. And interestingly, the thing that we're actually really worried about with the QTC is repolarization abnormalities. We actually don't care that much about depolarization. Now we do for other things, but for the purpose of this, where we see bad things happen is when someone has a repolarization abnormality, meaning there's a delay in how long it takes the cells in the ventricles of the heart to kind of recover after one action potential or cycle. And then bad arrhythmias can pop in, if you will.
Gotcha. So in layman's terms, I don't know why I think about the gun a bit like a firearm. Maybe it's because I'm in Texas. But so depolarization is like firing the gun, and repolarization could be seen as maybe reloading it. And if the rhythm of reloading it gets offset, the whole thing can jam.
I love it. Yes.
Okay. So
Perfect.
that's for all the non-medical people. Hopefully you
We
can
know
track with
psychiatrists
that.
love gun metaphors famously.
Yeah, sorry. Okay, sorry. Please continue. We're following now.
Okay, so the arrhythmia that we are really concerned about is something called torsade de pointe. which literally means twisting of the points in French. This is a polymorphic ventricular tachycardia. When you see it on an EKG, it basically looks like a waveform where you have high amplitude, switching to low amplitude, back to high. And it looks like it's literally like twisting around a single line. So torsades can present in many different ways. You may not know you're having it. You may pass out. You may come close to passing out. For some people, it looks like they're having a seizure. And you can die. You can have just straight up like sudden cardiac death. And that's the thing that we're really worried about. And so with the QT interval, this is the one marker on the EKG that is kind of classically known as the best marker of risk for torsades to happen.
The distance between these 2 points.
The distance between these 2 points.
So when this is what your EKG looks like, what is happening in the heart at that moment?
So the ventricles at that point are contracting really, really fast.
Both ventricles.
So yes, so fast that there's a risk of going into ventricular fibrillation, which is can kill you. So you get going very, very, very fast, and that's what's happening on that up and down waveform.
And it can kill you because you're not pumping the blood efficiently. It's just kind of like a useless sort of like spluttering pump.
Correct.
Right?
It's just like kind of waving in the wind like that. It's not refilling with oxygenated blood. So kind of hard to live, I would
You're
imagine.
kind of stuck.
Yeah.
Yeah.
Okay.
Yeah.
So that's scary stuff to work with as a psychiatrist, going from like nominally treating pretty healthy patients, which is like who I usually treat, especially in the outpatient setting, to now all of a sudden this life-threatening cardiac condition. One thing that I know we always get worried about in the hospital is like, how much do I actually have to worry about this? And I think that's kind of like where we're going from here on out. So the rule of thumb that I've been taught, and I'm curious like kind of what Margaret's learned in her CL realm, is like if it's kind of over 500, then the hairs stick up on the back of your neck, and you should like pay attention to like kind of lower QTC prolonging things or QTC prolonging drugs, because a lot of things can prolong the QT. But I've never really followed like a good or robust algorithm. I've just kind of seen a lot of people wing it, and they get kind of uncomfortable if it's over 500, and then with no other rhyme or reason, they're like, let's use a Abilify, which is less QTC prolonging than something like Haldol. But that's kind of all the reasoning I get. So I actually hadn't come across your tool before. So when we think about the risk of this actually happening in the hospital, how much should we be worried in just a normal patient to like the sickest cardiac patients?
Yeah. Well, I think that's where you hone in, is are they sick or not? So, the QTC is this marker of risk. It's going to basically show you on an EKG what is happening underlying. So that's one piece of the puzzle. But I think the greater piece is, what are all of the other risk factors that the patient has that may also contribute to their risk? And so when I see a patient with a lot of risk factors, that's when, with the 500 QTC, I'm getting worried versus a completely healthy person. So risk factors, what are they? Female sex actually is a risk factor. It's probably estrogen related, kind of unclear. Older age is a risk factor.
I'm going to say, does postmenopause help women? But then they're in the older age factor, so maybe not.
It's interesting. I've seen women of all ages who have had torsades. In fact, as I think about it, it's mostly been younger women, but they've had a whole host of things going on. So women, older women, it can certainly happen in men though too. If the patient has any cardiac problem already, that's going to be a risk factor. Certainly if they have a known cardiac genetic problem, or if anyone in their family does, that's something to think about. If they've ever had a prolonged QT in the past, you look at that. Certainly if they've ever torsaded in the past, that's a risk factor. A family history of sudden cardiac death is a great one that I think everyone should ask about. Actually, in any patient, if you are going to be giving a high risk medication, because they may not put together that they need to tell you that, and unless you ask, you may not find that. And that's a huge one, because that could be an indication that there is something genetic, and maybe that's never been evaluated. So that's one. Electrolyte disturbance is huge. So hypokalemia, hypomagnesemia, hypocalcemia. Typically, the Torsades patients I've seen have been extremely hypokalemic at the time of their event, like low, like ones, low twos.
Wow. And these are all electrolytes that help with repolarization.
Yes.
Which is our goal. Okay.
Yes, that's exactly right.
One of the reasons I first started asking Dr. Funk more questions about this stuff is given, I've talked about this in the podcast, interested in eating disorders, is this kind of like malnutrition or purging in eating disorder folks, electrolyte disturbance, and then if they're truly like cachectic or underweight, this kind of bradycardia, which I think is also another risk factor.
Yep. Sure is. Yes. So that's a setup for this to happen. And I've seen patients with very similar to what you've described, Margaret, who have had an episode. So yeah, I think anything that's going to either disrupt your electrolytes or cause GI losses. So even someone who is having, let's say, norovirus, and they're just like losing a lot, that could put them at risk. Let's say they have another risk factor, or they're, who knows what's going on, but that can happen. Certainly if your kidneys are not working well, your liver isn't working well. So if you're not able to clear certain medications that are higher risk, that can be an issue. Of course, overdose of certain medications is a risk factor. Bradycardia, like Margaret, you mentioned, typically is present when you see this happen. And so what'll happen is they'll be bradycardic, 50s, 40s, and then suddenly that heart starts racing, and then it goes into torsades.
These are subjective risk factors, and they're good to put together the picture. I guess I'm just curious what the numbers look like. Is this 1 in 100, 1 in 1,000, 1 in 10,000 that they're being modified, 1 in a million? Kind of where the initial risk starts, and then where these risk factors move them up and down on the spectrum.
Do we have the data on that?
No,
No,
we don't.
Oh, interesting. Okay.
No, there's no good data on that. And so how it's typically approached clinically is really a combination of risk factors. The more you have, the higher your risk is going to be. One thing we haven't talked about yet are the medications themselves. So like that's the piece we're worried about, right? And so the reason why medications cause this increased risk is that they actually interfere with that potassium. So like you mentioned, right? Like that's part of how the electrical system works. So that in order for a cell to repolarize, a bunch of potassium has to move out of that cell. And if the potassium is not there, then you are at risk. So one thing that can happen is that a medication can come in and block the channel that potassium goes out through. And then you have basically a delay of the potassium getting out of the cell. And that is what will make your QT interval longer. So the longer it takes for that potassium to go out, the longer your QT. And I think even more importantly than the QT is actually what your T wave looks like. The T wave is where this is going to show up. And it's when your T wave, instead of being just like a nice hump where you can see where it ends very clearly, it's like this yucky, slurred out, like long, very gradual slope downward. And that to me is like what makes me the most concerned when I see that.
So it goes from the Rockies to the Appalachians.
Yeah.
Basically.
Yeah.
Okay.
I think of it as a drunken T wave because it's like just slurring out, not where it's supposed to be, just let passed out on the line.
So that's really interesting. I never thought about like how these medications prolong the QT. So all these like various random things from antipsychotics to SSRIs is through interference of these potassium channels that kind of cause that to be sluggish all the way out. I mean, it makes sense. I feel like it's right in front of us, but I never put that together. It's interesting.
Yeah. Yeah. Now, there are a few medications that can actually interfere with gene expression of proteins that are necessary for those channels to work properly. But for the most part, it's literal direct blockade of the channel by the drug.
One of the things we haven't mentioned with this that I think is important, it was important for me, like as an intern in second year, to like start asking different questions about this, which was, we keep saying QTC, which is the QT corrected, as if there's one way to do that. And I feel like the most common thing that I like went to, I would say 4 times out of 5, whenever I got a consult on CL, like from a primary team in the ICU, like, hey, this person's QTC is 500. Can you, like, what do we do? Can we still give them Haldol? They're pulling at the lines. And almost like 4 out of 5 times, I would be like, let me just recalculate it and see and like look at the heart rate. Do you want to say a little bit about that? Because I know it's not for all hospital systems, but primarily the automatic read is Bizet's way of calculating the corrected one. And that, I will let you speak to this because you can do it way better than I can.
Yeah. No, but you're exactly right. And I'm glad to hear that you're telling them to recalculate because that is correct. So, so I guess backing up just a hair, the reason why we have to correct the QT interval is because at different heart rates, what we actually measure the QT to be is going to be different. So imagine like the heart's beating really quickly. All these beats are really close together. What you measure of the QT is going to be shorter than if you're bradycardic. There's a lot of space between beats. But that patient doesn't have differences in their ability to repolarize based on those different heart rates. So we've got to figure out like how do we correct that? And that's what the C part is for the QTC. And so what Margaret is mentioning is that most EKG machines have a built-in correction formula. Typically they use the first formula that was ever used back in the 1920s. It's called the Bizet formula. And it is a method to correct the heart rate. Unfortunately, what we know is that the Bizet we're going to say Bizet is bad. So you remember the 2 B's together. So Bizet is going to overestimate your QTC at high heart rates, and it's going to underestimate at low heart rates. And it's really not so useful. So if you have an EKG machine or system in the hospital that uses Bizet, most do, what you're reading is very unreliable, for one. And so it needs a recalculation. The other piece of this is even beyond the C correction part, is that you should always do your own QT measurement anyway. The machine is going to put together this amalgam of waves. It may not catch things like a slurred T wave, may not look at it in the right way. And so it's really up to you. If you want to do it right, in my opinion, you measure it yourself.
Do you have a caliper that you bring around?
I don't, but I rely on like our system's Muse that we have in the hospital on the computer. So I just like zoom in a lot. Sometimes I may get a little piece of paper that helps me measure.
Measuring pixels, that's more accurate than a caliper anyways.
Don't let the cardiologist do this. I hope
Just a little bit less
cardiologist
cool,
listening to a
honestly.
psychiatry podcast. Leave.
Yeah. So I guess, getting back to your original question, Margaret, about, the formula Bizet. Bizet is bad, but there are several others that are perfectly fine to use. And I think, there are many calculators that you can find online or apps that now allow you to plug in the heart rate, plug in the QT interval, and it'll spit out whatever the QTC is according to the other formulas. So Hodges is a formula, Framingham is a formula, Friedreichia. Friedreichia is now used by the FDA when they are doing drug monitoring. They used to use Bizet. I think in 2017 they switched because they also realized Bizet is bad. So any of those, I think honestly are fine. Just don't use the Bizet.
I remember being like, when I would be on call and I would be like waiting for some other thing to come in, whatever, or avoiding writing a note, I think MD Calc has ones where you can just switch between, like you can put in the information and then switch between the formulas just to see like how each of them corrected differently. And like Bizet's was always like, not always. If you were at the heart rate of 60, it was the same as the others. But other than that, it would be like 50 off or something, just to see how they calculate differently. And it does make a big change, especially because like a lot of the people that we're seeing in the hospital who are either agitated or sick in the ICU, their heart rate's kind of high sometimes especially when they get and they're asking us these questions. And so then if it overestimates the risk or overestimates, I guess, the QTC and therefore their risk of being on antipsychotic, it can prevent people from getting necessary medical care, which I know is something that you teach us every year, and is this combination of like complex medical ideas and calculations with complex interactions with a team in like a high acuity setting, I think makes it really hard for everyone involved on all sides.
Yeah, I totally agree. And
well, I learned it from you, so
I should agree.
Otherwise, I'd be scared of the QT.
I know, right? Yeah, everyone kind of comes to the table with their own thoughts. When I think if you can establish relationships with the people that you're going to be encountering most, like your ICU attendings, your ID attendings, because many antibiotics and antimicrobials can prolong the QT. Your renal folks, we actually didn't mention this as a risk factor, but if you're on hemodialysis, risk is huge of torsades. But one other thing, Margaret, that I wanted to mention about why it's important to measure and look at the EKG is a common error that is made is you'll get the call, QTC is over 500, and you go and you look at the EKG, and actually it's a really wide QRS complex because the patient has a conduction delay. And so if we go back to that piece about the QT interval is both depolarization and repolarization, and we don't really care about the depolarization, that's what's represented by the QRS complex. So when that's wide, we actually don't care as much. We're really caring about what is after the QRS complex. And so here's...
I'm imagining saying this like a medicine second year. It's like, and they're like, why are you weighing in on the psychiatry?
I will tell, I'm going to be risky, but say that, our psychiatry residents know a lot about this. And
I mean, yeah, we do. We do.
Margaret does. Yeah.
That's why I'm like, it's like, how do I word this? I'm like, I'm just thinking about this paper I read about Haldol. I'm like, slowly get there. Preston's going to show up with calipers on Monday in the hospital and be like...
And I'm going to tell everyone how much I don't care about depolarization.
I love that. So when you're in that circumstance and you see that 500, like this is not actually representing repolarization. That's the part we're concerned about. So there's an alternate interval that we can use, which is the JT interval. So the J
Justin
point...
Timberlake interval.
Yes. The J point is the end of the QRS complex. You can correct the JT the same as you do using one of the formulas to correct the QT. The cutoffs are different, and they're not well defined. But this is going to give you a much more accurate picture of what your risk actually is. Because often what I see is we get in this scenario, let's say it's a weekend, the primary team saw 500, over 500. They stop the antipsychotic, but actually, the patient has a bundle branch block that we're not actually concerned about. Or maybe they have a pacemaker, and because they have a pacemaker, they also have a wide QRS. And it's just part of being paced ventricularly. So they'll stop the antipsychotic, the patient decompensates, and none of that needed to happen if you had just looked at the EKG and understand what you're looking at. I think that's why it's so important to understand the electrophysiology.
That gets you through this huge initial gate, which is, should I be scared or not at the beginning? Because I think I see this on and taking CL consults all the time, is we share the fear of the primary team. Oh, I just take at face value the QRS or the QTC is over 500. Let me adjust the medications for you. But what I'm hearing from this discussion is it's important to take a step back and be like, do we even know that's true? You used your computer used the bad Bazette formula. You didn't even follow up with your own calipers. Me armed with Fredericia and the JTC formula just prove you we don't even have to worry. It's powerful.
I feel like this is an area similar to a lot in, I think, CL psychiatry or mind-body psychiatry, that beyond the overlap of eating disorders and cardiac concerns, you get this population of people that are medically complex in some way and psychiatrically complex in some way. And then there's a problem of lack of ownership, because it's in the specialization model. It's like, who has the full picture to make decisions when there's risks and benefits on both sides of that decision. And I think one of the things that we're speaking to with the team dynamic, and then this kind of thinking about how to do this well, is this kind of thing of is the team scared and we're scared, so we're kind of in this stalemate where we don't know what to do to help the patient.
Yeah, I think that can be really, really challenging. I think, hopefully you have access to medicine interns, and, you can help teach them as a consultant about some of these basic things. They will carry that on, and that tradition will continue. I've seen that happen in places where, this is not a known thing. And then suddenly you're like, okay, people know about the QRS, and we need to be looking at that. I think it's all about the relationships, and if you've got to set up a good relationship with your cardiology teams, so that they can trust you, that they feel like, okay, this person's got it, and that can take some time. It helps, if you're on a CL service, that they trust your attendings, and then as residents, you've got that going for you. I think in places where CL services are highly respected, it's easier. And there may be some places where, primary services don't even know what psychiatry is, right?
So it's funny you should say that, because I rotate at a couple different sites. We have 3 hospitals that we do CL here in my city, and the CL services have varying reputations among the primary teams there. So the type of consults they'll reach out to you for varies a lot on the complexity of things. And so it's interesting that all this expertise, all this knowledge almost doesn't matter if the social political framework isn't there.
Yeah.
Someone told me that 80% of it is really how you get along with people, and 20% is your objective competency.
Yeah. Because they've got to actually be willing to hear what you're saying. Right.
So Dr. Funk, I'm calling you. I'm the medicine intern. You'll go back to your residency for a second. Hey, this is Preston. I'm with medicine, calling for a new consult. So basically we have this lady, Miss Garcia. She's here for depression with psychotic features. She's otherwise medically stable, normoclinic, normal magnesiemic, and her meds are fine. We just have her on some trazodone 50 and sertraline 50, but because of her psychosis, we wanted to start on risperidone. Or is that how you say that word? Risperdal. 1 at bedtime, but her QTC is 515. So we were just kind of worried. And so that's kind of why we wanted to get you on board.
And I would say, sure, we'd be happy to see her.
So now kind of that's actually a very realistic consult that I feel like I would get.
That's a
Looking
good
back
consult.
at this, we have kind of the risk factors laid out. So we have a 35-year-old woman who's severely depressed with psychotic features. Okay, so there's her indication. She's on sertraline and trazodone, which both can prolong the QT, but she's normoclemic and normamagnesiemic and has no other risk factors. So her liver is fine, her kidneys are fine, her heart is otherwise fine.
Her family's fine.
Yeah. Her
So
no family history, but the QTC is 515.
what other medications is she on?
So she's only on these psych meds, the sertraline 50 and the trazodone 50.
Okay. So one thing for us to think about first is that sertraline is actually a very safe medication. And so I would not consider that a high risk medication at all. In fact, that's what I usually prescribe for high risk patients.
Wow.
Is the sertraline. Trazodone is interesting. It actually does have some risk to it, and is something that we should be aware of. But I guess what I would wonder about is, why is her QTC 515? Like what is happening in her heart to show up that way on the EKG?
And I don't know. I just read it off the machine. I didn't do anything else.
Yeah. So what we could start with is looking at the EKG.
Yeah. And so I guess to make it up a little bit more, we look at the EKG. We see that her heart rate is 55. She's turns out she runs marathons in her free time.
She's psychotic, and in between that,
she just got really depressed after she didn't qualify for the Boston Marathon, so that's why she's so depressed. And then she shares with you that she's had some anxiety and has been taking her friend's propranolol that she got from Mexico.
Okay. So, well, I think that could be something we could mitigate her risk with by getting rid of the propranolol, which may be making her bradycardic.
Yeah. So maybe the bradycardia is coming from the propranolol, and then we take that away and we rerun our formula through Friedrich. That's the right one? Friedrichsen? Frederica.
Yeah.
Mr. Frederick. And it's 470. So it turns out it was never prolonged in the first place.
So there you go. So I would say proceed, although I might not go with the 2 antipsychotics. Oh no, I'm sorry. It's certainly not Seroquel. Yeah.
So crisis averted.
Crisis averted.
Okay.
So I guess I have a question for you.
Mm-hmm.
Before the propranolol, did we recalculate the QTC?
I don't know. I just made this up.
Yeah.
But we can. Yeah. So we recalculated before. It was 490.
Okay. So I would have still said proceed.
Yeah. Mm-hmm. Okay. So here's the next situation. I'm the intern covering the ICU at night, and we have a patient here, Mr. Simmons. He's a 72-year-old. He's got vascular dementia. He's also here for pretty severe pneumonia, and he's delirious. He's on levofloxacin, Zofran, and furosemide. His potassium is 3.2. His mag is 1.5. He's pulling out his IVs. The nurse is kind of like, they're blowing me up right now. I really want to give him some Haldol, but I'm kind of scared because his QT is 520. So how do we think through this case?
Yeah. So he does have a lot of risk factors. I mean, you named pretty much all of them that one could possibly have. So,
Mr. Torsade de Pont, Monsieur walks into the hospital.
Yeah. What was that verb you used? Like, if they've torsaded before, they'll torsade again.
He literally 10 minutes ago went to torsade.
He's speaking French and he keeps saying, "I will torsade."
He's just twisting a string over and over again.
So for this guy, this is actually complex because IV haloperidol is actually not as risky as we think. And
really?
That we
Scott
treat
Beach
it.
paper, right?
That's right. Scott Beach paper. Yep. So Scott Beach and colleagues have a lovely paper all about IV haloperidol. They go through all of the evidence base. And really what we learn from that is that the risk of IV Haldol is essentially the same as PO or IM Haldol. And I think an easy way to conceptualize this is that, one, there are not many studies that can study, like randomized controlled trials to study torsades, for one.
Fair.
Because you just can't, right? Like that.
Mhm.
Yeah.
We'll make them sick enough to be in the
and-
ICU. And then
Exactly. So if you're getting IV Haldol, you're probably pretty sick. You probably have a lot of risk factors that are also contributing. And so when you study that in a patient where you can't actually parse out all of these other risk factors, that becomes part of the picture. And so I think there could be some scenarios where we could potentially give IV Haldol to this guy.
So I guess we could modify some of these risk factors before we give IV
Mhm.
Haldol. So
Yes.
I could give him 0.8 or like 80 milliequivalents of potassium, try to get his K back up to 4. You could
your
also,
ID friends if they want to
yeah,
change
if
antibiotics.
ID wants to switch from levofloxacin to something else that could
Okay.
be still covers pneumonia but not be so QT prolonging, and then we could hang a bag of magnesium sulfate as
Do
well.
we do that? Does that actually happen in real life clinically? Do we replete with K or magnesium?
We do replete with K,
Yeah.
and usually I think it's an IV push of the mag.
Okay. Like prophylactically? Before?
Yes.
Okay.
Actually, yes. Yeah, that's actually very wise to do if you can.
Mhm.
I mean, if he can tolerate it, that's the
Mhm.
thing.
Yeah. Right.
Like
right.
if he's super agitated, putting more lines in him may not be the greatest. But if you could, I would. Or maybe he could drink some potassium.
Yeah.
Orange
Diet
Put some
disgusting.
bananas at his bedside. We're like, we have some diet Kool-Aid for you.
With a lot of potassium in it.
But yeah, switching the antimicrobial could certainly be done.
So here's my question.
Yep.
I've heard IV Haldol was actually kind of an issue, but the other one is ziprasidone. What are your thoughts about that one being kind of this villain of the QT?
It actually is a real villain.
Oh.
Can we get the myth confirmed sign from Mythbusters on here?
I was
to
thinking
our
it was an
editors?
anti-hero, but it's a real villain.
Can we
It
get the
is
myth busted for Haldol
yes.
and then the myth confirmed?
It is actually real villain. Yep. It's
Stupid. Okay.
I think
Yeah.
like every time I've been on call in residency at one of our hospitals, it's like this is every 24-hour shift. It was like this would happen. So like we have a lot of. I feel like it's more frequent in some settings, and definitely my training. I feel like I've gotten very good. Like I think I did an ICU psychiatry elective for a couple of weeks and. We read all these papers. But I don't think that's common to all psychiatry residencies to like talk as much as we do in training about this.
No, this is unique. And I actually am going to 2 months of consults after this, so I will be taking all this information with me.
You're about to come with your calipers and a mission.
Yeah. And like I'm going to be
Yeah.
hitting people over the head with the JT intervals.
yeah.
left and
You
right.
should. Yep. I got to tell you what the cutoffs are, though, so you knew that too.
Oh yeah, please.
Yeah, so they're different in men and women. Now, there's one paper about this, so I think you can kind of estimate.
Okay.
Men 355 milliseconds and women 372.
For the
those
JT
seems very
corrected?
for the JTC. Yeah,
It's
correct.
It's gonna be tattooed right here.
Yeah.
Boom.
Yeah.
When I'm pre-rounding, I'll just be cross-referencing every EKG I see. Okay. Well, thank you for entertaining me on these real-life clinical scenarios. My hospital admin's coming here to usher us along to the final part that Margaret wants to get to.
Yes. Okay, we're going to take a quick break, and then when we're back, we're going to talk about outpatient clinical care and thinking about taking care of our patients who have been through or are going through cardiac concern, cardiac events, and how to best support them. So I guess when someone comes to see you in your outpatient psychiatry cardiology clinic, what's like the most kind of common presentation you're seeing that they end up seeing you?
Yeah, it's usually PTSD symptoms or just high anxiety after either a cardiac arrest or an ICD storm, which is where their implanted defibrillator may fire many, many times at what, in succession.
Hmm.
I've seen up to like 30 times that someone's been shocked.
And how often does that happen to someone with like an ICD? I'm sure it depends patient to patient, but is that is it expected if someone has one that it'll happen at some point in their course with it?
I think yes.
Hmm.
I think yes. I think it depends on what is the reason why the ICD was placed in the first place.
Mm-hmm.
So, ICDs can be placed for a number of different reasons. Sometimes it's primary prevention. Let's say someone had a massive heart attack and they now just have really bad ischemic cardiomyopathy and you know that
Mhm.
they may be at risk. They might implant one then. But you may have people who have had a cardiac arrest, present to the hospital, they live, and then it's discovered that they have either something genetic happening or whatever it is, and then the ICD is placed. And it's in those folks where it's pretty typical for shocks to happen.
Mm.
So to describe it for our non-medical listeners, an ICD storm sounds bad enough as it is, but
You're not going to say
to
it in the
clarify,
ICD
it's like
storm.
it's like being shocked, like the two panels like you'd see in a medical show. You said 30 times in succession. That's like functionally being
Similar.
tasered?
Yeah. So it's interesting that you bring up the panels. So what I've heard from patients is that getting shocked by your ICD is actually very different than the paddles, that the paddles are much, much worse and terrifying for a number of reasons. People have told me they can hear the electricity crackling in the air. They can smell burning. Like they're like just terrifying experience. Getting shocked by the ICD can feel like different things. Some people don't even notice that they've gotten shocked, which is interesting. Some, they classically describe it as feeling like you're getting kicked in the chest by a horse.
Mm.
I don't. Most people have not gotten kicked in the chest by a horse.
So hard to
Anyway, so
compare.
hard to compare. So it's different for everyone. Some people tell me like this is just terrible. And very traumatic. The other piece is that sometimes people are conscious, sometimes they're not.
Mm-hmm.
So they may get shocked 30 times and have not been conscious through any of it. And they usually do okay. It's the ones that what basically happens is like they'll torsade, they'll go unconscious. You get shocked, you come back, and then you fall right back into it. You get shocked again. And come back, and it just like keeps happening, and it can be for various reasons, not just torsades, but it's it can be pretty terrifying when that's happening to you.
And so they come to you with PTSD from this, and you say, "I have a medication, but it may also increase the risk of torsade."
So we do a really careful kind of risk assessment there. Most people are able to tolerate an SSRI. I do have a few people that I will not put anything on except a benzo, which can be safe in the right person. Sometimes I like that EKG looks so terrifying that I'm not going near them with anything.
Even like Zoloft.
Even Zoloft. I have a couple that I wouldn't even put on Zoloft just because they, the ones I'm thinking about, they have had many episodes of VT storm, ICD storm. It's just, it's a very recurrent thing with them. And Many of them have gone through, numbers of ablations, sometimes experimental therapies to try to get it under control. And so for them, like, I'm not going to add anything into the mix. They're also usually on one or more very high risk antiarrhythmics. And so that's another piece that I consider.
And so just thinking out loud, if they have treatment-resistant depression or PTSD, are other classic options like ECT, TMS, or ketamine are also off the table? Because I imagine they're meeting exclusionary criteria with their complex heart history.
It's a good question. I would say probably nothing is ever off the table. Like ECT, I mean, you can do ECT in someone with an ICD. You turn it off by putting a magnet on the chest over the ICD, and that will turn off the shock function so that they don't get shocked with the ECT. So you could do that. Of course, depending on the whole clinical situation. Yeah, I've not seen data with ketamine and risk of ketamine. It's a really interesting question.
I feel like with ketamine, the thing I always see is like any time we've done a referral for someone for ketamine, if they have like any cardiac issues at all, they like are auto no on clearance.
Yeah, I'm actually rotating a ketamine clinic right now, and that's kind of their motto. But I don't know if it's based off of data or just like abundance of caution.
Yeah, and I think that's where the question is, right? Like, what is actually the evidence? I don't know. I've not seen any QT data for ketamine.
What about lifestyle factors? Because one of the things I was thinking about is when I was on CL and we would do like heart eval or heart transplant evals, and just the amount of life like limitations that is different, obviously, than having like an ICD. But when you think about talking to your patients about lifestyle parts outside of medication, so like exercise, I'm thinking of like alcohol. Some people would argue diet and mental health connections, these non-medication things. Like, how do you talk to them about those three things?
Yeah, it's a great question. So again, it's going to depend on the patient and what is the cardiac issue for them. With transplants, it's actually pretty interesting that alcohol is contraindicated. Like, don't want to use alcohol. Diet is even really important for transplant patients early on in the course, so that they don't expose themselves potentially to pathogens that could get them sick because they are immunocompromised, much like a pregnant woman. Like, you wouldn't eat sushi or lunch meat. It's kind of similar in the early days of transplant. For everyone, it's kind of different. In many of my patients, they are trying to get back to some sort of exercise, and the fear component of doing that is the barrier. I actually have many athletes that I see, and people who have really like lived a lifestyle of health and being active, and so the fear component can be huge. So it's often like not me trying to talk to them about things that could help. They usually know, and it's more about what are the psychiatric or psychological barriers, or just barriers from conditioning standpoint. People with heart failure may not be able to work through just the fatigue that they have to be able to exercise. It's even someone who has been through, let's say, like a recent ICD storm that actually damages the heart when it happens. And so it can take some time to recover even from that. Just think about your heart getting hit with that much electricity over and over again. So I think many people, they really like want to get back to exercise. And it's a matter of, can they physically, and then can they overcome the anxiety and the fear? I will say, like an SSRI in that case, I've just seen be so helpful in so many people. It's really, really just, it turned things around for them.
Mhm.
It's kind of remarkable to see, like people terrified to just get off the couch to now, going to spin class. It's that's pretty cool to see.
You had mentioned at the beginning of the episode that, PTSD around this event that's happened. If there was someone who's in a general psychiatry clinic and they have a patient who maybe, let's say, 4 months ago they had a heart attack and they ended up needing an ICD placed, and they come and they're struggling, like they're coming to a generalist for the first time. What does it sound like when you're trying to help them suss out sort of this medical PTSD around this event?
So oftentimes they may not outright tell you symptoms. One, because they think that they're the only one that could possibly be experiencing this, or that they're crazy, or just this is so weird. I would never tell anyone. So we actually have to do some sussing out of the patient. And a really great tool for someone with an ICD is a scale called the Florida Shock Anxiety Scale.
What a name.
It's lovely, and it's actually it could be triggering, but in most cases, it's really validating for patients to see this scale for the first time, because it asks questions about how often are you, afraid of being alone when your ICD goes off?
Mm,
How often are you afraid of causing a scene when your ICD goes off?
mm,
Very common. How often are you afraid of shocking someone else in the room when your ICD goes off? Are you afraid to get angry or let yourself get angry? Are you afraid to participate in sexual activity because you're afraid of the ICD going off? So a lot of really discrete, specific scenarios it
mhm,
goes through in the scale. You don't have to use the scale, but you can take some of those things and pull them into your interview to screen. But it's often, avoidance of being in public, people seeing something happen if something happens, or being alone when it happens. And then many people, do avoid the place where they've been shocked before. I hear from a lot of people, like they'll keep the bathroom door open if they're showering or they're using the restroom, uh, in case someone can hear them, so they can hear them yell out if they need help or
mhm.
if they were to pass out. Uh, Not being in the same room where it happens, that can be a trigger. So, some very common PTSD things that you would
Mhm.
think about, but then there are these other more device specific things.
I think if I was trying to scare someone, um, I would use so it's a very backwards lead in, but hear me out for a second. I would use that kind of variable punishment, shock them randomly so they could anticipate what it's coming, and then you can almost induce like a learned helplessness around it.
Mhm.
It's like wearing this randomized shock collar, so I can really understand how these people become worried about doing anything.
Yeah.
The correcting one pathology is almost like operant conditioning to induce another.
That reminds me of things too, like just like an Apple Watch,
Mm,
or devices that are keeping track of heart rate. People become obsessed with those and can't stop looking and monitoring. They feel any little sensation in their body, and that
Mm.
fear of getting shocked might come up.
do you feel like, so let's say we help the PTSD or we help the anxiety medication wise. You mentioned your clinic is also, I know there's some group part of it that happens, and then your own psychotherapy approaches. Can you speak a little bit to that part of the working with this population?
Yeah. So I do a lot of DBT actually with these
Mm.
folks. I do a lot of radical acceptance, um, some distress tolerance, but the radical acceptance piece tends to be pretty big, as well as wise mind. And they're pretty basic concepts of DBT, but um, they tend to resonate with these folks quite a bit. Um, we talk about that. I think we do work on, setting goals of what they want to work towards. Sometimes that just may be like, how far do they walk?
Mm.
But honestly, for the most part, I think just the validation of someone being in the room with you and hearing your story and being able to say, I have other patients who tell me the same thing. That can be really huge, to know that they're not alone in it. And so that then I think brings me to, we have this ICD support group, which right now it's mostly an educational space. It's for a very large group. It's a hybrid on Zoom and in person, and open to anyone, anywhere with an ICD. And it's a great place for people to meet each other, to hear about other experiences, and just like know that they're not alone. That's the most important piece of it, I think.
Is that, you said it open, and like, is it, if listeners have this, like, is it open just to people in our clinical area, or is it open to the public?
It actually is open to anyone who wants to attend. And we could, I could share that link with you all, for anyone who's interested. We do it quarterly right now. My dream is to have actual groups, with different patient populations, when and if the time allows.
Well, let's get you more patients, and then we can be like,
I know. It's fun. I have a steady referral stream at this point. There are a lot of people suffering, and that's actually one other piece I think that's important. I hear from a lot of people, like, no one ever knows that I had a cardiac arrest, that I was dead, and then I came back to life. Like, we pay all this attention to cancer, right? But like, this is kind of hidden. Like, I don't tell people that I was dead, that I, had to be CPR'd and resuscitated. And so I think a lot of these patients just feel like they're hidden, and their stories aren't known, their experiences aren't known, and there aren't people like really who have their back. I think that's an important piece for us to think about.
I think you're right. I mean, as someone who has a family member with like an aggressive, who's had an aggressive cancer over the years, people always ask me like, how are they doing? Like, checking in even as the related person. But when someone has a heart attack, there's not really a language around recurrence in the way that there is in cancer, but there's still that real risk, and then the anxiety of the risk of, is this going to suddenly come back and harm me? But you're totally right. There's not like a language publicly for that. You don't ask like, hey, are you worried you're going to have a heart attack again? Like, that's not something we inquire after.
Yeah. I love how you say that too, about not having the language for it. I think that's totally right on.
Well, because how many people have a heart attack and then it's like, now your risk is 0 for this happening again? Like, it is like cancer in some ways. That way that it's not, I think with cancer, we have the public imagination that this comes back, and you're maybe always kind of anxious that it's going to come back. But we don't talk about this that way, but it is that.
We're not set up to like support or around like sudden events, I guess. Like, if a heart attack took 3 months to transpire, maybe we would have more language around it because it's like a battle. People have time to spread the word and get behind, but it's like you're doing fine and then all of a sudden you're not, and you're gone in the blink of an eye. Socially, like, the ecosystem can't like react to that very well.
We talk in like psychodynamic therapy with like the fear, like the metaphorical fear of annihilation, and like, this is an illness that can suddenly enter your life, and then you have to, there's a real fear. So I see how, I mean, I know Marsha Linehan in her like memoir talked about creating DBT from her own stance of someone who had lived with a proto-BPD sort of kind of symptom cluster, and describes it as like, these are skills for living when you feel like you're living in hell. These are skills for when you feel like at any moment the suffering is going to be so much, the anxiety is like unbearable. And so I think makes sense that radical acceptance and wise mind and then compassion are important for people who've died and come back.
Yeah, I mean, it's not a long descent into hell. It's a trapdoor that opens below you, and kind of like what Margaret said, anyone with BPD like struggles with that dysregulation or really not having any control over what can happen. So when you talked about using wise mind, it made a lot of sense to me. I'm like, if I had this random thing that I had no control over that could just take my life from me, I would probably need to practice the same principles.
It's like I mean, I know we called it the ICD storm, but it's literally like, hey, what if at any moment lightning could strike you? And I know it's like the illness part of that, and then also kind of literally like with what it's doing electrically.
Yeah, right. Yeah. No, it's exactly like that. And so, for many people, it's just terror. But I do think the radical acceptance piece is so huge here, because once you can sit with it, and I just like love it when I hear my patients say, it is what it is. I'm like, that's right.
It is what it is.
C'est
It
la
do
vie.
be that way
Yeah.
sometimes.
Well, this is a great segue because I think we're doing a DBT episode in a couple weeks,
Yeah.
so we can stack
Nice.
these together.
Nice.
Is there anything else that you feel like you want to point our listeners' direction or attention towards further learning or towards any kind of pearls of advice for people who work with these kinds of patients? Or are those
Yeah.
patients themselves?
Yeah. I think if you're working with these patients, know that they may not ever tell you anything. You have to ask. And though we do that, there may be so much nuance about what the fears are that unless you ask directly, there's a lot of shame around acknowledging that. So I think that's one piece that's important. From a QTC standpoint, practice as much as you can. Every EKG that you come in contact with, do the measurement, do the calculation. And when you do that, try to think about the electrophysiology that's happening. So it's like, why? Why is it 500? Why is my T wave really slurred and ugly? And if you can understand the why, that gives you so much more power with your prescribing and feeling like, okay, I can actually give the IV Haldol, or absolutely no, I will not give anything to this patient, which is very rare.
Mm-hmm.
But I think the more you feel confident with it, the better care you'll provide.
I mean, I got to the point at the end of CL rotations and working with you that I have a dot phrase in Epic that's like dot and then like an algorithm from the resource paper that's like, if you're interested in this, see this paper. They're never interested in it. But I was like, see and have, that's like the one thing I have for notes that has a citation. Preston wants to make fun of me so bad for that right now.
No, I'm thinking about if I could hyperlink it, make that a part of my Epic note.
You can. I do that with the
I recently
Osler
learned how to embed
algorithms.
photos, and it's been bad news.
They think their psychiatry notes are long now. Wait till they get to this.
All these screenshots of MRIs all over my note.
My notes are always purple though, which Dr. Funk might know from being on CL. Mine are edited to be the font I like. But hey, you can format them. Okay, well, thank you so much for being on with us, Dr. Funk. I know you're very busy. I think this is such a useful resource and one I will probably come back to. Every time we have a QTC lecture, I'm learning something different about it that I could not have known as an intern or different years.
Well, it's been a pleasure to be here and pretty fun. You guys are awesome. So thanks for having me.
Yeah. Preston, do you want to do the outro?
Okay, so thank you to all our listeners. We really appreciate all the support from season 1, and now that we're going full steam into season 2, we're really trying to incorporate all of your ideas and our ideas to achieve synergy, to use my corporate language there. I
Our
know this was a
hearts beat as
more like
one.
medical intense episode, and this is because we have a really like unique expert here, and we want to kind of give it a chance to go into the weeds sometimes, and then on other episodes we'll be coming back out of the weeds and do a little bit more forest type excavations. So if you want to watch the full episodes, you can check it out on our YouTube channel at It's Presro. And we'll also be posting on our Instagram account. I'm running the Instagram, by the way. It's just How to Be Patient. I think we have like 110 followers. So like slowly but surely we'll be directing
Be one of our first investors. Get in at the ground
our podcast
level.
content towards there. Yeah, just because like Margaret and I post on our socials and do other things, but we wanted to have like this united page for that. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Margaret Duncan, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Jason Portizo. Our music is by Omer Benzvi. To learn about our program disclaimer, ethics policy, submission verification, and licensing terms, and our HIPAA release terms, go to our website, howtobepatientpod.com, or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.